Okay, good morning, everyone. It's so wonderful to have you all with us on this beautiful June morning. I hope that you all enjoyed the past weekend. Though it was a little bit chillier than any of us anticipated, I hope you had a good one. My name is Katie Connolly. I'm the Vice President of Development and Community Engagement here at Newton-Wellesley Hospital. I joined Newton-Wellesley about 18 months ago, and it has been a complete pleasure getting to know our hospital, our community, our clinicians, and of course, all of you. Today is our event is just an incredible example of the vision we have for clinical excellence and our commitment to putting the most advanced tools in the hands of our exceptional physicians. We've enjoyed a great year so far at Newton-Wellesley, including our gala, which was last week. And it was wonderful to see many of you there with us. Thank you for being with us. And overall, we're so grateful for your support. Before I introduce Dr. Philippides, I just want to cover a couple of housekeeping items. At the end of the presentation, we'll enjoy some time for questions and answers. Many of you actually submitted questions in advance, and thank you for that, so we will cover those. But you can also use the Q&A button at the bottom of your screen to type in questions that pop up for you during the presentation. As well as you're looking at your screen, if you'd like the slide to be larger or smaller, or the photo, the video to be larger or smaller, you can slide, toggle, drag the bar between the two frames to adjust that. And again, thank you for being with us. Thank you for taking the time to learn about this project and to consider the many ways that you can choose to support our hospital, our patients, and our community. And now it's a pleasure to introduce Dr. George Philippides. Dr. George joined us in 2014. He is the chief of the Division of Cardiology here at Newton-Wellesley Hospital, and he is the director of the Elfers Cardiovascular Center. Dr. Philippides, thank you for being with us. We look forward to your presentation.
Thank you, Katie, and good morning, everybody. I too would like to thank you all for taking the time to join us today and for your ongoing interest in and support of your community hospital, Newton-Wellesley. Before I introduce our keynote speaker, Dr. Parpos, I thought I would take a few minutes to give sort of an update and an overview of the Elfers Cardiovascular Center and cardiac care in general at Newton-Wellesley Hospital, because I think understanding what our goals and visions are for the center will put into context the really powerful and impactful technology and program that Dr. Parpos will be describing. And I think it'll help it sort of come together so you can see how essential it is for what we're trying to do moving forward. So let me go back 10, 12 years, I've lost track, and fill you in that at that time, the leaders of Newton-Wellesley Hospital, in conjunction with some community leaders, took an evaluation, took a look at cardiac care at Newton-Wellesley Hospital, and they came up with a few conclusions and then action plans. First, they felt that the cardiology care at Newton-Wellesley Hospital was quite excellent, that the nurses and doctors and technicians working at Newton-Wellesley were very well trained at some of the best academic medical centers in Boston and really around the world, and the care was good. But they also looked at another thing, the demographic tidal wave coming down the road. And what they noticed was the population was aging. With an aging patient population, they knew that the amount of chronic cardiac disease, hypertension, atrial fibrillation, heart failure, chest pain, and heart attacks, that those diseases would be going up in numbers. And Newton-Wellesley Hospital, as then put together, would not be ready and able to deal with the huge demand. So to deal with that huge demand, they came up with an action plan, and that was to create a new cardiology division and a new cardiovascular center. And with that in mind, again, the leaders of Newton-Wellesley Hospital, along with some very supportive community members, and the Elfers family is certainly at the top of that list, although there were many others, put together a cardiovascular center. And the center had a few very basic but really important objectives and visions. Next slide, please. The plan was to build a multidisciplinary cardiovascular center that would expand cardiac, vascular, chronic disease management, and interventional services here within the community, while leveraging and strengthening the excellent and strong relationships that we have with the Mass General Hospital and Brigham and Women's Hospital. basically bringing academic medical center care here to the friendly confines of Newton-Wellesley, but also access better than anybody to the amazing hospital and the programs at Mass General Hospital and Brigham and Women's Hospital. Put another way, I'll get back to that later. Again, the plan focused on the demographics, the aging of the population, and we were very focused on making sure that we were excellent in what I would call sort of the big food groups of primary care cardiology, things like high blood pressure, atrial fibrillation, heart failure, vascular disease, and coronary disease and heart attacks, which we'll hear more about in a bit. It was also really crucial that we focused on being patient-centered and primary care physician-centered. So what do I mean by that? The patient experience is very important at Newton-Wellesley Hospital Cardiology. Yes, we deliver great care, but we want it to be in a way that makes friends and families and patients feel really sort of at ease and cared for. And at a community hospital, you can really sort of do that because of the scope and the scale that we have here. We're smaller, we're friendlier, we can sort of add that. And to quote Bill Elfers, who helped put this together, we wanted to create the premier primary care cardiology program in Massachusetts. Kind of sounds audacious. What do we mean by that? We mean that we do not want to create Mass General Hospital West or Brigham Women's Hospital Light. We don't plan on doing bypass operations here or heart transplants or any of those coronary care high-level procedures. Those are best done downtown. But we are focused like a laser in being as good as we can be and really the best around at those basic cardiology things again. High blood pressure, atrial fibrillation, heart failure, all of those things, with the understanding that we have a closer relationship with the Mass General Hospital and Brigham than anybody. So when a patient of mine or Dr. Parpos needs to get into town or needs to get into a sub-specialist, our patients here at Newton-Wellesley and the Elfers Center have access to those like no other patients. And that's sort of the back and forth relationship that we're trying to build. Next slide, please. So the leaders of the hospital and community leaders raised significant funds and then put together this center. And as you can see, it's in prime real estate of 2 West within the hospital. And it's very efficient. When you exit the elevators, which are shown here by the little sort of triangle in the middle of this floor plan, if you turn left out of the elevators on the same floor, you'll run into our cardiology clinic, which is attached to our offices, which is attached to the non-invasive testing area over here on side A. This means all the doctors and nurses and technicians are working and sitting and on their computers all together. It leads to a lot of collaboration and a lot of efficiency. Going through a short walk down the hall to the right into side B, you walk into 2 procedural suites, and I'll show you a picture of them. They're amazing, cutting-edge, high-tech science fiction procedural suites, which is next to our recovery area, which is where all the nurses and doctors and technicians who perform these procedures sit and work and, yes, collaborate together. And that's right next to our cutting-edge pacemaker and device clinic, which is right next to our fantastic cardiac rehab program. So you can see all on one floor, all together, all organized around collaboration are all of the cardiovascular services. Again, this is very, very good for the patients, very patient-centered. They go to one elevator, one waiting area, and from that, they have access to all of the amazing cardiovascular programs that we're offering. Next slide, please. I want to give you an idea, if you haven't seen our cardiovascular center, what it looks like, because it's really beautiful. Again, it's very nice for the patients, and we're proud of it. To the left, you can see the main entrance area, the take-lift family waiting room. You can see, again, it's beautifully lit, beautifully, endowed with art and all that stuff. Very nice for the patients. To the right, you can see a picture of our open floor plan cardiology clinic, where Dr. Parpos and I spend a lot of time seeing patients. It's a really great place to work. Next slide, please. This is the cardiovascular prevention room. And you can see this is where we sit down with patients and their families. It looks more like a living room than it does a doctor's office to talk about ways that we can make them and their families heart healthy. Next slide, please. To the left is a picture of one of the 2 Slotnick procedure suites that we have, where we perform a whole array of cardiovascular procedures. We place defibrillators and pacemakers here. We open up arteries in the neck, in the body, in the legs here. All kinds of other vascular procedures are done in this area. I talked to you before about collaboration. We have many physicians who work at the General and the Brigham who perform procedures there, who also come to the Slotnick procedural area at Newton-Wellesley and perform them here as well. And I'm proud to say that all of those guys, almost to the last person, say that this is the best procedural suite that they work in. The technology is the best, it's the biggest space, and they love working with our staff. So this is a fantastic resource for our patients. And then to the right, you can see our small but very, very busy device and pacemaker clinic. We're sort of breaking records for the amount of patients that we're seeing there. Next slide, please. And then finally, our excellent cardiac rehab program. So for those of you who have not had the opportunity to come and see our space, Stefan and I and Katie would love to host you if you'd like to sort of come by and we can do a walkthrough. It's something that we're really, really proud of, and we think it's been going great. So why do we think it's going great? There are different ways you can sort of tell. First of all, we receive feedback from you, our patients. Patient questionnaires are sent by email and mail to patients very, very frequently. And we're happy to say that so far, the feedback that we've gotten in regards to the facilities and the physicians and the nurses and the techs have been quite good. But we're also proud to say that there's other more objective evidence for how we're doing. Next slide, please. Been cited by the American Heart Association, which is really the premier heart society in America, for the excellent care that we give our patients in the areas of heart failure and atrial fibrillation. So when patients with these diseases are admitted to Newton-Wellesley Hospital, the American Heart Association looks at different elements of the chart, of the documentation, to see how we care for patients with these diseases compared to other hospitals. And then they sort of give us a comparison. And I think for the last 5 years running, something like that, we have won the Gold Plus and Gold Awards in these areas. Not shown here, we also have gotten the Gold Award for stroke care. So the American Heart Association considers Newton-Wellesley Hospital a center of excellence for the care of heart failure, AFib, and stroke, which are 3 of the big 4 or 5 primary care cardiology problems that I cited earlier. So this is fantastic stuff. But there is one area that has continued to change in regards to the way that it's diagnosed and it's treated. And I've got to say that Newton-Wellesley Hospital is playing a little bit of catch up in this area. And that's why we're meeting with you today. And that's in the area of chest pain, coronary disease, and myocardial infarction or heart attacks. Next slide, please. So heart disease, and specifically heart attacks, remains one of the leading causes of death for men and women in our country. To put this in perspective, about 1 person dies every 40 seconds in the United States from a heart attack. So during the time that I've been talking to you, many patients have passed away from a heart attack. What's scary is about 2 in 10 of these deaths from heart disease occur in adults who are less than 65 years old. So it's really important that we are able to accurately and quickly diagnose blockages in people's arteries, which are the reasons people go on to heart attacks. So as of now, the gold standard for making this diagnosis, the most definitive way, is a cardiac catheterization procedure. But a cardiac catheterization procedure is an invasive procedure. It requires that patients get a catheter placed in an artery in their body, either in their groin or in their wrist, that is threaded up into the heart, and then dye is injected and pictures are taken to see if there are blockages. It's precise, but it's not easy to perform, and there is some risk in the invasive nature of sticking catheters inside patients' body parts. Traditionally, what is done in community hospitals is a stress test, which you guys all know about. Stress tests are great because they're easy to perform and they're non-invasive. You don't need to stick patients really, but stress tests can be imprecise. Sometimes they can say that there's no problem when there is a problem, so they can miss things. And other times they can say that there is a problem when there's not, which will lead to more and more testing and a lot of expense. So you might be asking yourself at this point, well, wouldn't it be great if there was a non-invasive test, one that did not require catheters in your heart, that was easy to perform, that was fast, and that you could do at a community hospital like Newton-Wellesley Hospital? Well, guess what? There is such a technology, and that is exactly the technology and the program that Dr. Parpos will be talking about later today. Next slide, please. It's this technology, coronary CT angiography, which is very easy. A patient shown on the left goes through a CAT scan. We have many of them in Newton-Wellesley Hospital. This is easy technology to do. And within a few seconds, these amazing pictures shown to the right spit out, which are almost like a 3D rendition of the arteries. So you can see very rapidly, are there blockages in the arteries? Is this the reason for the chest pain? Or are the arteries wide open and the patient's chest pain is not because of the heart? This is the difference between being admitted to the hospital, being sent in an ambulance downtown to Mass General Hospital for a cardiac catheterization to open a blocked artery, or sending somebody home with no further hospitalization and much less worry. So you can see having something this rapid, this easy to do is a true game changer. And as Bill Elfers said, it really is one of the key things that we need to keep us on the road to being the premier primary care cardiology program in Massachusetts. So I'm ending up with Bill Elfers. Next slide, please. And I wanted to thank him and his family one more time. As you probably know, we lost Bill this last year in 2021. And Bill was an amazing supporter and friend of the Cardiovascular Center, which bears his family's name, and also of Newton-Wellesley Hospital Cardiology. And Bill was very open about the fact that his family had been touched by cardiac disease at a fairly young age. Bill felt that he had been very fortunate in life and was very enthusiastic about giving back. He felt that the work that he did here at Newton-Wellesley Hospital to improve cardiac care was a real important opportunity for him to make the community that he loved more heart healthy. And so as you guys listen to my comments and listen to Dr. Parpos and participate in the discussion with Katie Conley and her group, I'm hoping that you also look at this as an opportunity to work with Stefan and I to leave our legacy, which is to make this the most heart healthy community and our hospital sort of a leader in cardiac care across the country. So with that, I'd like to thank you for your attention. And it's now my pleasure to introduce our keynote speaker, Dr. Parpos. So Stefan Parpos is the Assistant Chief of Cardiology and the Medical Director of the Inpatient Cardiac Service. He is a virtuoso clinical cardiologist, just an absolute great clinician, and patients flock to come see him. But more to the point for today, he's also somebody who thinks systematically and programmatically. Stefan is very good at taking care of patients one-on-one, but he also likes to think of how we can take care of populations of patients and how we can make programs. And it was really Stefan who looked at this technology now several years ago and came to me, he got the bright idea and said, George, we have to have this. This is the future. This is where the best diagnosis for coronary disease is going to happen. And when we get this technology, we will be on the cutting edge of sort of first-rate care for cardiac disease and heart attacks. You won't find anybody more knowledgeable or more enthusiastic about this particular program. So with that, it's my pleasure to hand over the Zoom podium to Stefan Parpos. Stefan.
Thank you, George. Next slide, please. All right, so here's a picture of my father's office in the early 1980s. He was a software engineer. And sadly, this is also where I spent many of my Saturday mornings as a child. Yeah, that's right. While most of my friends, spent their Saturdays competing against each other in soccer matches, I competed against these large mainframe type computers in virtual chess matches, right? Kind of like the original Virtual Visit, only with room-sized computers and a thermostat that was about 50 degrees. So shivering, in my winter jacket, I would write software programs on Saturday mornings that scripted the movements of my chess pieces. And the reward for slaving away at pages and pages of computer code was basically I'd get a printout that would indicate the statistical probability that my program would defeat the computer, right? Yeah, some kind of reward, right? I know it would have been nice to have like at least one soccer trophy, in my room. I remember telling my dad, and I just reminded him on Father's Day, actually yesterday, how much I hated playing statistics in the dark, and I vowed that, my career path would take on a completely different setting. First of all, like I would be warm in my office. It's like 75 degrees in here. So mission accomplished. I told him, listen, I'm going to be a people person. I'm not going to be a computer geek. No disrespect to any computer people in the audience. I would be a cardiologist. Next slide, please. So how did this happen? Look at me. I'm here speaking to you in a computer. about a computer, right? A very sophisticated computer at that. Next slide. So, well, when you practice cardiology as long as Dr. Philippides and I have, humility becomes commonplace, right? Despite our vigilance to safeguard our patients against the horrible consequences of atherosclerotic heart disease, too often we just can't get there in time, right? It's heartbreaking to witness the premature loss of life. We often wish we could have recognized the disease, sooner and acted sooner. So when an innovation like this CT scanner comes along, one that allows us to recognize the disease so much sooner, one that allows us to really clarify the diagnosis, to help us streamline our investigations, to enable us to have better decision-making capabilities, and allows us to reduce risk. When something like this comes along, it's time to bring back the computer geek and start scanning. So I'm very grateful for the opportunity to get to share with you some examples that illustrate the wonderful utility of a machine like this and how we envision it'll help our patients and our community. And so next slide, please. Before the examples, let me take 2 minutes for a quick crash course in cardiac anatomy and physiology. So the blood supply to the heart via the coronary arteries, actually the coronary arteries wrap around the heart, and the blood supply kind of flows through those arteries and delves into the tissue of the heart through smaller branches. And so all arteries of the body are essentially made the same way. They're just 3 sheets of muscle layers kind of stacked on each other and wrapped in a cylinder. And so when we talk about cardiovascular disease, we're really talking about plaque or atherosclerotic plaque that's building up on the inner lining of those cylinders. And if that plaque builds up to a point where the blood flow gets shut off, then the tissue that needs that blood supply, in this case, the heart, doesn't get the nutrition it needs and the tissue dies. And that's what a heart attack is. Next slide, please. So we can evaluate these coronary arteries non-invasively with the CAD scanner we're discussing today, or invasively with the heart catheterization that George alluded to. In that scenario, what you do is you basically poke with a needle into an artery in the wrist or down in the sort of towards the hip groin area. And we follow that with a catheter, which is just a hollow plastic tube that we run up into the body all the way down to the heart. And then we pour some dye down the coronary arteries and create sort of the coronary tree similar to what we see on the CAT scan. Next slide, please. The treatments include medications or mechanical interventions. In the case of coronary stents, a catheter traverses that area of plaque, pushes the plaque along the arterial wall in that cylinder, and a metal scaffold is inserted. We call that scaffold a stent and keeps the artery open. In the case of bypass surgery, the obstructing plaque is not interrupted, but rather a vein from the leg or an artery off the chest wall is used and sewed down to create a path diverting blood flow around the occluded area. Next slide. Okay, so now let's get to some examples. That's your anatomy and physiology crash course. Here's an example of a patient of mine, a 44-year-old gentleman who's completely asymptomatic. And he's on the eve of turning 45, which, by the way, happens to be the age that his father died from a massive heart attack. He has a young family. He's worried that he may suffer a similar fate to his dad. Doesn't know if he has dad's genetics. And even though every piece of statistical information that he's been told has led him to believe that he's extremely low risk to have any heart issues over the next 10 years, nevertheless, he's still worried because of that family history. We did indeed plug his statistical information in, and indeed, he's very low risk to have a heart problem in the next 10 years, less than 1%. Nevertheless, we don't exactly have a way to reconcile the genetics. We don't know the entirety of the disease-forming gene mutations that lead to atherosclerosis and to vulnerable plaque in the arteries. So he could be sitting on big-time genetic risk. Next slide, please. And indeed, he was. Here's his scan, his CT scan. He has a severe, with the arrow there, he has a severe atherosclerotic plaque that's causing 99% narrowing of the early part of a major coronary artery. It hasn't completely occluded yet, as the artery you could see reconstitutes blood flow after the level of the obstruction. But make no mistake, this was the widowmaker about to happen. An occlusion would have led to a major, massive compromise of blood flow involving a large area of the heart that needed that blood supply. This would have been a massive heart attack. So running the scan in this otherwise kind of low-risk patient, as you can see, really clarified the diagnosis and allowed us to really really efficiently get him to the cath lab, put in a stent, and avert any jeopardy. So we really lowered his risks and streamlined his investigations moving forward. Next slide, please. Here's another example. This is a patient of mine who's a 72-year-old female. She has very common risk factors, hypertension, hyperlipidemia. And she's been describing this sort of unusual, just kind of a variable chest symptom for about 6 months now. And when you listen to the history of it, it really doesn't sound like it has an origin in the heart. It doesn't sound like it originates in the heart, at least the symptom doesn't. Nevertheless, she's quite astute, and she is aware that women don't often present, with the classical angina or the classic chest pain type symptoms. And statistically, she's very high risk to suffer a cardiac event in the next 10 years, over 23%. So do we need to do an invasive procedure on her? Next slide, please. We chose to do a heart CT scan. And here is her CT scan that demonstrates a gorgeous looking heart that's completely free of any coronary atherosclerosis. She absolutely does not need to have an invasive procedure done, and her symptoms are not in any way heralding a heart attack. So having the CT scan clarifies the diagnosis, and more so, as it often does, it reclassifies the predictive risk of our standard risk calculators, such that we can streamline our downstream investigations and we can avoid unnecessary invasive procedures and those risks and thereby lower her risk. Next slide, please. I use this example to illustrate the progress in both the hardware and the software components of these scanners over the last few years, which has really enhanced the spatial resolution of these images. And it's allowed us to see more than we ever could in the past or earlier generations of the scanners. It wasn't long ago that we couldn't use these types of cardiac CT scanners if somebody had cardiac stents, which happens to be a lot of people, right? And so we just couldn't see inside the stents. Next slide. Here's an example from our scanner. Again, another gorgeous looking heart with, exquisite, coronary arteries, plaque-free stents. And you can really get a nice sharp image of that. And that certainly clarifies the diagnosis and helps us moving forward in our plan. Next slide, please. Also new to these scanners are computer cardiac blood flow simulations. So we're going beyond coronary anatomy here into the realm of physiology, virtually that is, so stay with me, okay? So the older we get, the higher the probability that we will have some degree of atherosclerosis in our coronary arteries, right? And we'll have some distals of plaque in there. That's not terribly surprising, as atherosclerosis is the most common disease-forming process, amongst human beings anywhere on the planet, right? But not all coronary atherosclerosis is destined to become blockage, right, or cause problems. So how do we know which of the coronary plaque is problematic and which of the plaque we should leave alone, right? Well, we can try to figure this out invasively, right? So in the top bars here, the top row, we can make that coronary anatomic tree by introducing the catheters and doing an invasive catheterization. When we identify an area of plaque, what we can then do is take another wire, put it through the catheters, go through that area of plaque. Hopefully we don't break off any of the plaque and give you a stroke or heart attack. And hopefully we don't use poke through the artery and rupture it with the wire. So there's some risk there, but we'll try to do a good job. And once we get the wire in position, we can increase blood flow there with some medications and measure pressure differentials. And we can obtain a value called an FFR. The FFR is a ratio between the maximal achievable blood flow in that diseased coronary artery and the theoretical maximum flow in a normal coronary artery. So an FFR ratio of 1 is considered normal. The more disease, the lower the numerator. So less than 0.75, we consider that to be physiologically obstructed. We say that plaque there looks like it's hindering blood flow in a meaningful way. And those are the cases we consider to put in a stent. And that's how we figure out and anatomically if there's a physiologic correlation that needs some kind of intervention. Interestingly, now we could actually do this by CAT scan or by CT scanning, and we can actually create an FFR CT virtually, which correlates very well with the invasive FFR. Next slide, please. The magic sauce comes from three-dimensional modeling using the CT scan data, and as well as from some physics. We utilize equations governing something called computational fluid dynamics. And we put the two together. Next slide, please. We mix it all up, and out comes a little, what we see here in blue and green and yellow and red. This is a patient-specific model of coronary flow. So what you're looking at is somebody's anatomy and physiology, actual anatomy and physiology, all sort of displayed in one picture. And so where the blood flow is good, if you go down an artery where you see green and blue, whether or not there's a little bit of plaque along the wall of the heart, the blood flow is pristine. Where there's yellow, you can see an area of yellow there. The blood flow is still not hindered, but that may be an area we want to watch a little closer, maybe a little more time on the Peloton, maybe a little more Lipitor. Where you see an area in red there, that little area of red, that's physiologically obstructing plaque. And so, that the blood supply, that comes from the tissue that needs that little twig there, it's at risk. It's at risk to have a tiny heart attack. So if that plaque did close off, that area of the heart would lose some of its blood supply. It'd be a very tiny heart attack, right? So do we want to fix it with a stent? Probably not. Probably wouldn't even notice that heart attack, or it wouldn't change things. So again, we can take a look at these pictures and we can figure out vulnerability in the heart, and we can use the information to determine, really how we should act. It really does help us clarify the entire picture, streamline our approach, and reduce risk. In this case, I probably wouldn't try to put a stent in that little area, because that would probably create more risk than good. And so all this, again, done with a computer non-invasively. Next slide, please. And that's it. Thank you very much. Looking forward to taking some questions.
Thank you so much to both of you, Drs. Philippides and Dr. Parpos. That was so wonderful. And we already have a couple of great questions that have come in. So I'm going to dive right into it. And please, all of you, feel free to add questions as they pop up for you. And we will also bring some that came in through registration. So my first, and if you don't mind, I'll just ask Dr. Philippides and Dr. Parpos, you two can decide who's best to field some of these. So this first is coming from our friend Bruce. He says, I'm a 75-year-old Medicare patient. What conditions or symptoms must I have for my PCP to order me this test?
So that's a really good question. So at present, and this is a moving target, what is basically approved based on evidence and in our experience, the insurance companies will pay for, are any patients who have chest pain that needs evaluated. Or if you've had a stress test in the past and there was any question as to whether or not the stress test was showing a problem or not, that will be, that's okay. If you had a stress test and the stress test said things are fine, but you continue to have discomfort, that is also an indication. If you have any evidence at all that the structures of your heart, the valves, the heart muscle, the vessels are abnormal or damaged, that is also an indication. But I think what you might be asking, I want to be clear, what if you are just worried that you might have heart disease, but you have no symptoms? You just want to sort of get beautiful pictures to clear it. As of this day, that is not approved. So an asymptomatic person with no reason to suspect coronary disease, so far that is not being covered by the insurance companies. Having said that, Steph and I often joke that we seem to not be getting much pushback when we're ordering these tests. I get more pushback when I order certain cholesterol medications from the insurance companies than I do from ordering this test, which I think says something about the lack of logic within the insurance world. But I will tell you that, the way things are now, if you're asymptomatic and there's no reason to suspect heart disease, you might get pushback from the insurance company. But if you have chest pain or any of the other things I mentioned, it's gotten actually pretty easy to get it. That answered the question.
That was great. Thank you. We have another insurance related question and interesting, a detailed question. And is an unusual calcium score a good reason to have this scan? And can it be done electively, even if the insurance company will not pay for it? So part of that you've already answered, but I'll leave that to either one of you to tackle.
Stefan, calcium score?
Sure, yeah. So when you get this kind of a scan, there's two things, right? So when we look at the plaque composition as it appears under a CT scan, right, the atherosclerotic plaque in the coronary arteries, there's about 20% of the plaque appears calcified, and about 80% kind of in general would be non-calcified. So the idea of the calcium score is to sort of look to see if there's a big burden of just a calcified plaque along the wall of the artery. It doesn't tell you if an artery is blocked or not. What it does, it helps inform decision making. As you know, it helps with the statistical risk prediction. This score, this test goes beyond just the calcium score, where we actually inject some dye in, and we can see that non-calcified plaque, so you get more information. With the advancements in the technology, it used to be that if you had a lot of calcium, we couldn't do this test because the calcium would create a lot of artifact. In most cases now, if you've had an unusual calcium score, you could still have this test, which would lead to incremental information that can be very useful. And so, you know, when we talk about just indications that are covered or not covered, again, it's you know, even the case I showed, right? There was the 44-year-old. There was some reason, you know, beyond just we want to do it, you know, in the family history that, you know, led to a good convincing of the insurance company to move forward. And so, you know, depending on the particulars of the calcium score, and not everything's straightforward, as you're probably alluding to, you know, there could very well be a good reason to look further. It just depends on the specifics. And so a lot of that is you know, in the paperwork and what we submit to the insurer.
Thank you so much. I have a couple of, okay, I have one coming in through the chat, which is, does the dye injected during the CT have any long-term side effects? And what, if you know it, what type of dye is it?
It's iodine-based dye that has recently been under in the press for you know, a GE shortage, a supply shortage, because of a major factory in China that closed down temporarily for COVID. So there's a lot of press about the dye. So the dye, you know, there are people who are allergic to the dye, and that's you know, this is dye we've used, you know, for medical purposes, for catheterizations, for CAT scanners, for a lot of different utilities for many years. We always check somebody's kidney function, because it does filter through the kidney and get processed through there prior to injecting anybody with this dye. In the cases where the kidney function is normal or near normal, this dye should be metabolized quickly by the kidney and should not have any long-term side effects. In the cases where somebody has, you know, some advanced kidney disease, then it's more complicated, and you know, we take it case by case.
Thank you so much. Okay, we're so many questions coming in. I've been saving this one, but I don't want to miss it because I love it so much. I am a member. I was saving it for last, but there's more coming in, so we'll get to Stevens also. But Michael asks, I am a member of Atrius, and most of my doctors, including my PCP, are affiliated with Atrius. Can I avail myself of ELFR services? Dr. Philippides.
I love this question, so I want to answer it. Yes, absolutely. We'd be happy to have you. Please join us. But all kidding aside, you do have to check with your insurance company to see what they will and won't cover. Depending on the coverage, they'll cover a visit or testing. But what you don't want to do is come in and have me or Dr. Parpos, well-meaning, get a test and then find out that your insurance company didn't cover it. So the answer is yes, we'd love to have you, but check with your insurance company first. And by the way, while we're talking about insurance companies, which is one of my least favorite topics, I did want to just circle back and make sure that Mr. Metz's question was answered. You can do this on your own dime. So if the insurance company says it's not an indication that they respect, there are folks who basically say, well, you know, for whatever reason, I've got family history, I had some concern, and they can do it, and you will get the hefty bill. Just want to be clear on that.
Thank you for that clarity. It really is. It's an important question that many people ask. So that's important for us to be very clear. This next one's just giving me such a giggle. So I'm going to lead with this, with the tail of it, which is from Stephen. And he says, tell Dr. Parpos that I take exception to describing angiography catheters as just a tube. So something tells me he has some deeper knowledge about that technology, and he'll take that up with you privately, perhaps. But he also is curious to know our thoughts on, do we think that the CT will ultimately replace the standard treadmill stress test for diagnosing atherosclerotic plaque?
Awesome question. Thank you, Steve. They are very versatile tubes and very dynamic, a real triumph in engineering for sure, those catheter tubes. So, so I don't think there'll be a replacement. Sometimes the way, heart disease keeps company sometimes. And, even with a standard treadmill, stress test, oftentimes we're gleaming other information. We might be looking at the heart rate response or the blood pressure response to exercise or something arrhythmic that's happening. And so there won't be a replacement. I think that for the purpose of understanding and diagnosing coronary atherosclerosis, I think the rise of the CAT scanner, the frequency of use of CAT scanners will there'll be a slight decline in the standard stress test, but it won't be a replacement.
Thank you for that answer. And I think maybe this might be our last question. I am noticing that, Mason, you have your hand raised. I'm not sure, I'm not able to call you in to actually ask a question live, but if you have a question, you could type it in for us. I'll take this one last question unless we hear any more. And it's back to the cost of this. There's a lot of curiosity about that. And I don't know that we know the answer to this.
I know the answer.
Oh, great. Okay. So the question from Tad is, if there are no symptoms, what's the approximate cost to pay for this test privately?
So the cost to pay for it privately at Mass General Brigham is about $4,700. Now, the other approach you could take, you may notice the Greek last names here. You could, we do know where you can get it done in Athens, so you could take that $4,700 and get it done for probably €300 in Athens, and spend the rest of the money in a nice hotel in the Acropolis and eating wonderful food, healthy Greek food. So there you go.
Amazing.
That's there you go.
There you go, Tad. Who knew that this would come with some healthcare travel, healthcare tourism travel tips as well. So that's I think a great question for us to conclude our Q&A. I will just, if you could give me the next slide, Katrina, I'll just share with everyone. So you know that this is incredible new technology that we're bringing to Newton-Wellesley so that we can deploy it on behalf of all of you and all of our community members. We are, the total cost of this project is $8 million. That's $5 million for the technology and $3 million to enable the space to receive it. We anticipate it will be on our campus early fall and then up and running in some order after that, once we get all of that work buttoned up. We are working to close the gap towards that 8 million by raising 3 million, and wonderfully we've raised half of that already, thanks to some of you who are here on this call. So Dr. Philippides kindly referenced my fabulous team. You'll see Jamie Mulligan's name at the bottom of this slide. Jamie and her team will be really delighted to speak with anyone who's interested in helping us ensure that this technology comes and is in part supported by our community so that it can then do its important work on behalf of our community. And I think with that, I will just end as I started, which is thank you for being with us. Thank you for sharing your Monday morning with us. Thank you to Dr. Philippides. Thank you to Dr. Parpos, not just for your time and your knowledge and your education of us, but for the incredible care that you give to all of us. And enjoy the rest of your day and enjoy the start of your summer, everyone. Thank you so much.